will last about 45 minutes, and after her presentation wraps up, we will definitely have time for some questions, so don't be shy. You can type in your questions for Teri at any point during her presentation, but just know that we will address them following her presentation. There's also a chat box on the right-hand side of your screen, and if you have a comment or something you'd like to share with the group, feel free to type it in there during the presentation as well. I do try to keep my eye on that, but I don't always. So if you really want a response and if you have a question, just make sure to type it in the Q&A pod. And just also a reminder, we will be recording tonight's session because we hope to post it online at a later date. So just keep that in mind as well. And I'm just pulling up the slide here, and then I will hand it over to Teri Currie.
Hi, everybody. Thank you for all taking the time to come out this evening. I'm going to review some topics about advocacy, and I'm going to say I'm going to talk about the website as well, because one of the things that I was able to do over the last few months is really explore the CDA website and all the things that it had of value, but a lot about helping you with the advocacy. I also want to start by saying thank you to CDA and Boyan Young, who enlisted me for trusting me to share this information without causing the dreaded death by PowerPoint. So hopefully everybody will be able to hang through that. And as you heard, I'm Teri Currie, and just to give you a little background on me, I'm a certified diabetes educator. I've been working in diabetes for just about 20 years. I've worked with children with diabetes, diabetes in pregnancy, as well as type 1, type 2 adults, and a lot of work with insulin pump therapy and CGM. Also, just as a self-disclosure, because you're going to no doubt hear about it, because I'm terribly much of a storyteller. I've had diabetes for 25 years, and I also have a child with diabetes. And you can imagine, based on that I've had to act as my own advocate many times over the years. So I wanted to share with you one of those really important lessons that I learned along the way, which is getting informed and reaching out to those people who are. So also, I just want to say that this presentation is by no means everything, and it's about reaching out and researching, and I would encourage if some of these are very close to you to take it that next step and further the research so that you get the best out of your diabetes journey as well. So I've never done a webinar, I will disclose that. I'm very used to having people in front of me and being able to read them, so I'm hoping that I won't go too fast, but please do ask questions. I really enjoy being able to ask those, and we can do that at the end of the presentation, and I will hope to be able to do that. Okay, so let's get started here. And is the volume okay?
Yeah, you sound great, Teri.
Okay. So advocacy, first statement that's most important, you are your own best advocate. I just wanted to put that out there. Again, it's about knowing yourself, knowing what you need, and knowing how to get it. And I think some of us, we stop at know what you need and aren't sure how to take that next step. So hopefully this will give you some insight, but also some encouragement if there's things that you think you need to go forward with. So the topics that I am going to include are the disability tax credit, looking at the disability savings account, insurance, driving, employment, and I added the kids with diabetes in school, specifically at the end for those that maybe that's a topic you don't want, but it is a very big hot topic in British Columbia in particular, and not saying that our kids are going back to school, but at any point there's been some serious changes, as well as if I do blabber on too fast, we've got a couple extra slides at the end as well. So we'll start here with tips for just general tips of advocacy. Always, again, knowing your facts. Sometimes it's really important to make sure that you're getting the credibility. You can have all this information, but if it's not based and researched, it doesn't get the people hearing it the way they should. So, and again, that leads into clear and concise messaging. Relationships. Sometimes when people are trying to be advocates, the emotion gets the best of you, and you forget about nurturing relationships and working collaboratively, and that's really important to be successful with organizations. And I say that having dealt with insurance companies and Revenue Canada and all those places where you just want to scream, but really it's really trying to nurture that. If you have a message, you need to engage others to help you and support you, which is, again, what CDA is here to support us with as well, so that you can have your voice be heard. And always remember to say thank you. That's one thing, I think we think it, but sometimes just don't verbalize it quite as much as we should. Okay. So again, starting with the tax man. So I've included some of the CDA position statements because, again, I really renewed my relationship with the website, having been involved with CDA a long time ago and then not having updated it, and so much has changed. And so I was looking at their position statements here, and then you can read it. You can read it on the slide, but for those of you that maybe aren't actually seeing it, the statement is the Government of Canada should institute a system of enhanced tax credits wherein people with diabetes would be eligible for consideration for a non-refundable tax credit or refundable payment specifically designed to reduce the burden of higher medical and treatment costs. That kind of encompasses everything you can imagine, but taking it that step forward and what's actually happened so far. And sometimes I take for granted that the things that are available, but they always weren't. And the first thing that I learned about was the disability tax credit. And I'm going to say it's fairly new. It hasn't been around for a really long time. And initially, when it was first brought forward, it was only for people who were on insulin pumps. But it did get reassessed, which was really important. And they adopted the policy so that recognizing that people on insulin, could get that extra support. So if you look at the statement from the Canadian Diabetes Association, the financial burden of diabetes and its complications can be extensive, and people with diabetes can incur costs that are 2 to 3 times higher than those without diabetes. And, you look at people who are, depending on your income, that really changes for each person. And that's what this application is about. It's called the T2201, and it does need to be done in collaboration with your physician. And that's an important piece because you end up having to advocate for yourself and educate, because when I know that when I first heard about it and went to my physician, he didn't agree with it and wasn't willing to sign that, and didn't feel that, how could I prove that I spent 14 hours per week on my diabetes management? Now, for me, and for many of you, you may think, well, oh my gosh, I feel like way more than 14 hours. But, they're very specific about what it is that you spend those 14 hours on, and you don't have to agree with them at this point, but I'm very verbal about not thinking all of them really make sense. But definitely putting that application. So one of the things that happens is if it's a child and they're under 18, they combine the child and the caregiver's time required for activities and administering insulin. But for those applicants that are over 18 and require insulin, they consider insulin a life-sustaining therapy. So they say, okay, you need to prove to me that you spend 14 hours per week so that you can be eligible. So there are worksheets actually on the internet that I've actually seen that you can find, but just sitting down and taking the time, and they count monitoring your blood glucose levels, preparing and administering insulin, calibrating necessary equipment, and maintaining a logbook of blood glucose levels. I guess more what I'd say is understand what they do not count in that time. And one of the things that always gets me is carbohydrate counting. I think that takes a lot of work, and even with lots of education, it's still a really hard thing. It doesn't count the extra testing and work involved with exercising or recouping from a low blood sugar or a high blood sugar. So just knowing that those are not a part of it. So there is even a process a little bit where you can actually backdate it as well. So definitely talking to somebody about it is very helpful, and your accountant may know about it, but again, talking to your physicians, I think more and more physicians are starting to become more open about it, and especially if you can show them that evidence. The other thing that leads into the next subject is the disability savings plan. And again, this is something that I did not know about, and I heard about it after doing some investigating by hearsay. And it essentially is a program that you can be eligible for if you're eligible for the disability tax credit. I've put the website there, but I'm going to read more from my notes on this one because it's somewhat new to me. But it's a grant in the amount that the government contributes to you, and they will pay matching grants. And it depends on your family's income and the amount that you contribute. So, depending on how that goes, the RDSP or plan can get a maximum of $3,500 in matching grants in 1 year and up to $70,000 over the beneficiary's lifetime. A grant can be paid into it on contributions made to the beneficiaries until December 31st of the year they turn 49. Where this is really impactful is in lower income families, and I know with my son, who's a student and has just started working, he has a very low income, and he's now learned to put away some money each paycheck into this so that he can get that support. There's also so the Canada Disability Savings Bond is an amount, and this is a little bit different amount, paid by the Government of Canada directly into it. The government will pay bonds up to $1,000 a year to low-income Canadians. No contribution has to be made to get bonds with disability if you meet that disability criteria, and the lifetime bond limit is $20,000, and it can be paid into there until they turn 49. So again, this is reaching the needs of those that do require it, and I know that sometimes in my work, what I've seen is that diabetes is sometimes that last thing that makes it really, really difficult to cope with that. But so I wanted to continue on with that. So hopefully I'm glad that we bring this up, but for some of you, I wonder if that's not new information, and if not, to get in there, because the bank was very helpful with it, I must say. So there are other tax credits for families with diabetes. These ones I took, you can see the resource, the EndoDiab, that's the BC Children's website for diabetes. It is such a good resource of information in general about diabetes. I use it for lots of things, even with adults that have diabetes, and so they have got these other ones here for you. So moving on to insurance, I didn't have as much luck when I was trying to really investigate insurance as I would have liked. I've included here that, again, a position statement that, people with diabetes should have access, and access that's not going to break the bank, essentially. Coverage at all types are reasonable. And we have to talk about, what is reasonable. And it's not just having diabetes. There's a lot of other things that people are having to pay more premiums for, and that is definitely the reality as we are aging and dealing with that. But again, one thing that I've learned is that let me see if I actually put it on there. I'm thinking it, but did I actually put it? Oh, I lost my slides. My slide's blank. Okay. Do you have them?
Do you want me to scroll back for you?
Yeah, way back. Way
back?
Yeah, and these ones are all blank. Yeah, keep going, keep going.
Keep going?
Yep. Back. Keep going. Okay, keep going. Okay, there.
Okay.
See if I can get back my slides. Okay. Okay. So, yes. So
Perfect.
insurance, there we are. Thank you. Some insurance points that you really need to know the lingo about. So failure to disclose your diabetes can affect or render a contract void by the insurer. So you have to think about what kind of insurance you're applying for. One thing is, like, once you've obtained it, you don't have to report. Let's say you got your life insurance and then you get diabetes. You don't have to disclose that you have diabetes if you're staying within that policy, because you can, if it's an ongoing policy. But if you choose to actually increase it, at that point you are required to do a medical again, and at that point you could see insurance premiums change. So in those cases, what I was encouraged to do was to actually just start another policy, so that you don't disrupt what you have on that original policy. So from that point, to look at it. The other thing is, consider an insurance broker to do all the shopping around for you. They're really helpful, and they will, you give them the circumstances, tell them what you're looking for, and they can find ones that have sort of different testing that needs to be done. The other thing is about insurance policies, thinking about if you have a really good one with work and you're retiring or you're leaving, is there the possibility that you can actually continue that one? Because sometimes when you take things from an employer package, you can just continue with them. So it's something that you need to talk to your employer about specifically, but it can be helpful. I just wanted to put a little bit about travel insurance. Just making sure that there is that disclosure of diabetes with this, and that they're really good about covering pre-existing conditions. I mean, again, looking at all that, and there is a rate. I mean, you are prorated without a doubt, but they also now are so much more educated, as are the insurance brokers, about diabetes, and they ask a little bit better about those questions. And but you want to make sure that your diabetes is stable, or any other disease, chronic disease you may have, or any other thing, because if something is not stable, that can also null and void. I have definitely found that shopping around makes a really big difference, and also checking with your employer policy. If you have extended benefits and even credit card insurance, you would be surprised at how many different plans you already have in place. So, just to do those phone calls, because I know for a long time I didn't realize how much insurance I had through my employer. And then I also ended up with 2 credit cards that also had some coverage. So just check that out as well. Now we're going to talk about driving, and I'm going to hopefully slow down a little bit so we don't finish this too early. But I really love this picture. It kind of sort of says it all, above 5 to drive. That really plays in well to all the guidelines that we do have already in place. I'm going to go through them, and I will say that I have sent an email to CDA as well as our chapter, but just about, and the superintendent, about clarification about diabetes and some of the rules around it. It says diabetes, but I wanted to clarify, is it type 1 diabetes, type 2 diabetes with diet and exercise versus oral meds, and as well as insulin, that sort of thing, because I think those all play an important piece as well. So looking at your statement here, again, right there on the website, but the key thing that comes out here is individual basis. I think that more and more we're recognizing that we need to look at each person individually, because somebody can have diabetes for 40 years and be very well controlled and have no complications of diabetes that have any impact on driving, but you can have somebody who's had diabetes for a long time, maybe didn't know about it, have never been on any medication at all, but has some significant complications. They may impact some of the driving. So needing to know that individually, which is why they involve the physician. So the clinical practice guideline statement that I have put here is guidelines that we abide from as clinicians. So, and this had quite a large review done. They do update them. They sort of started them in about 1999, I believe. But in general, a patient is considered fit to drive if he or she is medically fit, is knowledgeable about controlling the levels, and how to avoid severe hypoglycemia. There's enough clinical papers out there to state that it is really important that people know how to take care of their diabetes. Even if you have a great A1C, if you're not treating lows correctly, then that's a problem. So here is some statements out of there. So fitness should be individually assessed. Drivers should be active in their management, and including that treatment of lows. It was interesting that they put in there having the meter close and treatment close, and they were suggesting that the visor would be a good place. And I'm thinking to myself, I don't think I'd want juice or Dex tablets up there. Things getting warm, but you do need to make sure it is in close area. And it's really important to test your blood sugar just before you drive. And if you're taking a very long drive, it should be every 4 hours, just to ensure that you're not going low. And sometimes, quite frankly, when you're driving, you can pull really high, and it's good to know that as well so that you can treat accordingly. So levels, going back to that B5 to drive, it sort of says the EG test prior to driving. Do not drive if you're less than 4, and that, of course, is our hypoglycemia threshold that we work with. But do not begin to drive if your blood sugar is between 4 and 5 without a carbohydrate treatment. And again, I sit back and reflect and wonder how many people, first of all, really do test before they get in their car as they're about to go, and again, that a very important piece that we take for granted. And then knowing that you're between 4 and 5 and really having a little bit of carbohydrate to ensure that you're not going to fall. Once a low is treated, so if you were driving towed over and were low, the guidelines do say that you should not drive for 45 to 60 minutes after an effective treatment. And I know the very first time I read that, I was like, are you kidding me? I mean, I can't imagine that length of time. But in the guidelines, it does provide evidence that it takes between 45 and 60 minutes for you to return cognitively to where you need to be to drive. Looking at commercial driving, that's something that's considered to be a sensitive or safety-sensitive kind of occupation. So I like to look at them specifically because they do have their own guidelines. So on insulin in particular, they need to have a yearly medical examination. There's actually, I apologize for my slides being very wordy, but there is that medical involves many pieces. A self-assessment needs to be completed, as well as physicals, eye exams, A1Cs every 3 to 4 months, and downloadable meter, and the minimal testing needs to be at least twice a day. And you're actually supposed to provide 6 months worth of logs. I don't know for sure that they actually make people do that, like pull out all that, but I know that when I was working in the clinic in the days where we were responsible for taking care of these documents, we had to download the meter and actually sign off that we were seeing twice a day for 6 months. So just to be aware of that. And their guidelines are a little tighter in that they need to test the blood sugar 1 hour prior to driving, again, plus every 4 hours. And if it's less than 6, require carbohydrate treatment. Actually, just before I kind of go on past that, just one more point about commercial driving. And again, this is just for the people that are commercial drivers, they know all this, but just knowing that it's different everywhere and that commercial drivers are not allowed to drive in the United States if they're on insulin. You know, in Canada, we have these guidelines, but they do not. They say no. So be aware of your own provincial driving guidelines, because I recognize that we have some people on here that are outside of British Columbia. So I'm going to go back to what we have and looking at the Office of Superintendents of Motor Vehicles for British Columbia. So they have a really nice document on their website, but some of the things that I picked out that, again, you know, with doing this research, forgetting about is that they are talking about all people with diabetes. It doesn't matter if you're just on diet therapy and exercise, you still need to disclose that you have diabetes. And when at any point, if you begin to take a secretagogue, which is to say that is those are glyburide, diamacron, those medications that make your pancreas produce more insulin, those are medications that can cause you to have hypoglycemia. If you are to start one of those, or if you ever start insulin, you're supposed to report that. What I noticed is that each province had different rules about who reports it. In some provinces, a physician is the one that's supposed to report it, but in BC, the patient and the physician should be reporting it. But especially when it comes to the severe hypoglycemia as well, and even hypoglycemia awareness. If you have one episode of hypoglycemic awareness, you're supposed to report that. Because if that happens, at that point, they start all over again. And I don't want to, I've put here new rules and reassessment, but essentially what they do is they have you take the medical and then they monitor you more closely. So you, instead of doing every 5 years, having that medical or randomly, it feels like sometimes, they're going to do it every 6 months to a year until that they're convinced that everything is stable and you can go back to that normal time frame. Okay, so moving past driving. So employment. A person with diabetes should be able to have any occupation that they're qualified to do. No different than anybody else. There are a few things, so there are a few times when that is where it becomes sensitive, which we'll talk about. So some of the things that are included in this are breaks being provided. So even if other people have to work through, they are obligated to allow you to have breaks so that you can test your blood sugar, take medication, and have some kind of nutrition. And one of the things is, and this is really about being an advocate, so I think back when, you know, when I was first nursing and working night shifts and I was trying to ask for support to, you know, I couldn't work through and I was low and there was no support. In fact, she said, well, my head nurse said, maybe you should have considered a different profession. And, you know, and again, and I didn't go any further, and I, in fact, left the position that I was in, so that because I really just didn't feel like, even at that point, and again, this is going back many years, I engaged the union, and you know, I'm thinking, this is crazy. But there just wasn't any support at that time, and people weren't voicing the current. People weren't even saying that they had diabetes, so nobody was bringing it forward. So there is support to do that. The only type of thing that is absolutely, I guess, frowned upon is limitation is armed forces. If somebody starts on insulin, so if they were to get type 1 diabetes, that would be not going to happen. So I talked about those limitations. So there are safety-sensitive positions where they're considered a person with diabetes. They can absolutely do these jobs, but they really need to be individually based and look at different things. And it wasn't so long ago that you couldn't be a police officer or a firefighter. And when I think about even commercial pilots and even private pilots, it's amazing how much where we've come in the last 10 years when I see that we used to put up these postings in our diabetes clinic showing, somebody was a firefighter now and police officer, because it was such a struggle for them to be able to meet the requirements, or they were just plain out said, no, we don't want to deal with this. So this is just an example of some of the drivers. And I think that we're into a new age where we're going to see that people aren't afraid of having people with diabetes in these positions. I've been involved with a lot of young type 1s that are now becoming professional drivers, like race car drivers, and getting those pilot license. And I mean, it's a really exciting time to be able to, not have to have that stigmatism behind you and the discrimination. So duty to accommodate. So CDA has said employers have the duty to accommodate employees with diabetes unless they can show it causes undue hardship to the organization. So that's about that safety too, and if somebody dismisses somebody. So undue hardship needs to be as it relates in terms of health, of safety, and cost, and they do need to be able to provide that. And there is a list of things that, and when I was reading the document, I know it's terrible, I was kind of giggling to myself, but I guess I forget that really these sorts of things are still happening. We live in communities now that are more so accepting of diabetes, but there's lots of communities around Canada that it's not so much, people are just not aware of it. So again, I guess that's where the education comes in, and recognizing that the best thing that you can do is educate in your employer because they don't understand that that's not going to impact. And I always thought people, typically are even healthier and they took care of themselves and were very motivated. As far as disclosure to your employer, your medical information is confidential. If you are already working, you do not need to inform anyone of your diagnosis. And I say that, and at the same time I'm thinking, I like for people to tell somebody that they have diabetes at work. It's always such a good thing to have somebody that has your back, and I don't think of it as anything that is, as bad. And I don't know if it's because I've been in the healthcare field my whole life, but I really think that you shouldn't have to hide it. But I know some people do feel that they need to, or they've heard things at work, and I guess all you need to know is you do not have to do that unless you're in one of those safety-sensitive positions where it needs to be reassessment on merit. Okay. So there is legal protection, and again, I thought some of this I was learning about. So there's the Canadian Human Rights Act, as well as the Charter of Rights and Freedom. So there should be equality and protection and no discrimination. And there are provincial human rights codes. But when it's time for filing a complaint, there's some important points about that. Number one is there are deadlines that you need to abide by on how quickly you need to process. You need to meet those, put that complaint in, and you need to do it to the right person. And you'll see here on the list, determining who you need to go for the Human Rights Commission officer. If you're federal employee, you need to go to the Canadian Human Rights Commission. But if otherwise, you go to your provincial or territorial group. So again, knowing where you need to go and knowing you need to do that quickly. And engaging people like the CDA to help you and being informed. Okay, so we're at 7:30 now. I'm gonna sort of switch hats over to the kids in school, again, this is quite a hot topic in British Columbia, and I feel like it's been a hot topic for a very long time. And I know some people feel like it's been a long, long road, but I really think that there's been a lot of good things that have happened along the way, and we have made very, very good strides. So again, we know that it can be a real hardship to parents and guardians when they have a child in school trying to get assistance with the daily diabetes management tasks. I know that there's been some other talks about the differences between type 1 and type 2 diabetes and control, and so most of the people I'm thinking that are participating, you have an understanding of what an A1C is and how important control is. So poor management can really seriously affect their academic performance. If they're high, you can't learn. If you're low, you can't learn. And for a long time, I think that we've been leaving children at suboptimal control because, and really conventional therapy is the best we could do so that it didn't have to be somebody being at the school all the time. And I can't tell you how many parents I had where, a mother or even sometimes a father was having to quit their job because they could not deal with a very small child in grade 1 or grade 2 and trying to make sure the blood sugar tests were done, making sure they got insulin, the lows were treated accordingly. And so the great thing is all about communication. So over the years, despite not having the policy that's coming in as of September, if there was good communication between the school and the parents, amazing things could happen. And that goes back to our first slide about advocacy and about encouraging that nurturing environment and relationship and seeing how much could happen. And I can tell you I've taught a lot of school staff about how to deal with insulin pumps over the years very easily because there's a very strong relationship between the school and that family. So communication and educating everybody involved is really the vital thing if you want success. So what's happening is we look at education on type 1 diabetes as well. It's one thing to know how to do a psychomotor skill or just to do something, so test a blood sugar, program a pump or give an insulin pen, but understanding why those things are important. Why do I need to treat low blood sugar immediately? Why can I not just give that child juice and leave the room? And if they don't understand the pathophysiology behind diabetes, and up until now, schools were not allowing glucagon. They were okay with having EpiPens, but if a child went unconscious, they would not give glucagon. So it was really about educating, okay? And so these are the strides we are making, and nursing support services is a very big piece of that, and in helping with the individual care plan. And there's some amazing teachers assistants out there, and I say I've got here SEE or SEA, and they're called TAs, and there's lots of different acronyms, but the assistants that are in the classroom. So as I was searching for resources to assist with the school, without a doubt the CDA website had some really great documents. The standards of care for children and the kids with diabetes in their care, as well as the diabetes clinics that are in the province or territory have some amazing websites to help educate about school. And even the JDRF website has some toolkits for families. The one other place is Child Health BC, and I know I didn't know about Child Health BC until I got involved with them with some processes that happened about standardizing diabetes care for children in all of BC, so that a child, being diagnosed in Smithers is getting the same care that somebody was getting on Vancouver Island or in Vancouver. And they are an awesome organization that are really about evidence-based. And so of this last year, they got together and developed an evidence-based informed document called Diabetes Care in School Settings. So essentially they went out there and they really took a look at what was happening all over looking at all across Canada and the U.S. and assessing what is the best care for children in the schools, and where do we want to go from here. And what they found out was that every school was different in BC. It didn't really matter even what community. It was so inconsistent to be in the same actual school district, but it was about the relationships and about the knowledge. So if you had a principal that was very open to it and a teacher that was very open to it, then that child there was getting different care than a child down the street at another school who had a principal that did not want to deal with diabetes or was not comfortable with it. So it was really important for them to bring forward all this data so that they could get together, get this document together. And then what we saw was that the Ministry of Health and Education and Children and Family Development developed a provincial document to support students with type 1 diabetes in the school setting. It is available, and it is something that really, when you look at which places have the best care across North America, it's very interesting, and they went that one step further. So it's going to be a really great program. So the big changes that are happening is that insulin administration. So MDI, which is multiple daily injections, the injections for lunchtime will now be able to happen, but it has to be by insulin pen. So there will be no drying up of the insulin where you're trying to look at amounts. The one thing that has been a little bit pushback on that is that, if they're taking snacks or different things through the day, there was the question of, why can't you give Johnny some extra insulin at snack time or here? But the one thing about multiple daily injections is you're not able to calculate the insulin on board that's there from the last one. There's calculations and algorithms that do that, but you can't do that on a pen. So when it comes to insulin pumps, there are little different rules in that the boluses can be given at recess, lunch, and 2 hours after lunch. Those will be when the tests are done, and they are required to use the bolus calculators. And for those of you that are maybe not familiar with insulin pumps, the insulin pump is like a little mini computer that actually retains the child's goals, their blood sugar goals for the day, what their insulin sensitivity is. So 1 unit of insulin will drop them this many millimoles, as well as their carb ratio. And some people have different carb ratios for the different times, and you can calculate all that in there. The only rule is that there's going to be no overriding, which I think is really important. We don't want people making those clinical decisions. These are going to be independent care plans to support the children, and anything above and beyond this is going to need to go to the parents. So as of September, and again, I giggled when I said the kids going back to school because we really don't know yet if our kids are going back to school and when. But delegation is a process that's tailored for each student. So the nursing support services are the ones that are going to be teaching the assistants in the school, and it's going to take time to implement. I mean, a lot of families they literally banded together as advocates to make this happen. It was absolutely amazing, and they came to the table with diabetes educators and nursing support services and really made it happen. But there has to be some patience up front for sure, and parents will need to be responsible until all the staff is fully trained. In one school, it may be only one child, but in other schools, there could be many. So I always have to throw that get involved. Just, again, when there's advocacy involved and with the CDA, making sure that there's lots of ways that you can get involved to help other people with advocacy because it takes great people to get that great goal, and there's lots of ways to do that. Okay, we're at 7:45, so I'm going to go to the extra slides because I kind of like these ones, and I get to get a little bit more of my own stories in here because I think that you learn from your own mistakes, and I always like to be the N of one, trying things out. So hospitalization can be a very scary thing for a person. Especially there's difference between having a planned surgery and having to be in emergency and not knowing what's going on. I can't stress enough that you have to speak up and be your own best advocate in a hospital. You need to educate and make sure that you have somebody in your life, whether it's a family or friend, that can act as your backup and really understand that. And, we might say that's for type 1 diabetes, but it's not just about diabetes. Any health condition, you need to be your own advocate. And be prepared. Always carry your updated information. Make sure it's not outdated because, sometimes you're not actually feeling that great, and it's really hard to do that talking. And even if it's something like a migraine and you're in the hospital, it's very difficult. And without a doubt, hospitalization is a stress, even if it is for a good reason. I'm trying to think what a good reason would be, but it always seems to put people's blood sugars up, and they will have to temporarily change their medications. Someone will go in the hospital on oral agents, so pills, and they'll be on insulin for the time. And so you need to ask people, okay, I'm taking insulin now. What does that mean? Like, is my risk of hypoglycemia more? Ask the questions, especially if somebody, and I used to have this on my unit, where someone would come in on metformin, but they'd start on some kind of steroids, and the blood sugars were going up into the 20s, and they were having to take insulin, and there was hypoglycemia involved, and not feeling in control, and you need to take back some of that control when you're in the hospital, and really reach out to others. Traveling is a joy with diabetes. So putting up those tips, we talked about insurance, making sure you have that travel insurance and making sure that things are stable. But if you need any changes done, don't wait until the last minute to talk to your educator or your physician about adjusting medications for time zones and stuff like that, because believe it or not, it can take us a long time to make all those adjustments, especially for people who are on N and R Humalog. The hours, when there's hours and hours of change, it can really change it. So we spend time mapping it out and trying to make it as easy. Certainly with an insulin pump, it's sometimes easier to make those time changes, but it's still really good to be informed about it and how to do that. Medications, always pack double of what you require. And for some of us, that's like bringing an extra suitcase. But it's important that you have it and you have the labels on them, the original boxes, and even with your insulin, make sure that you've got your original bottles, because in other countries, especially if you're traveling, they may be totally different bottles. They call them different names. The only thing that seems to be universal from what I've seen is the color on the insulins. Like if it's an orange, it'll tend to be an orange there, but you just can't rely on it. And the last thing that you would want is to get, if you're used to taking a rapid acting, to get a like a regular acting, I guess, an R or a Toronto. So make sure that you take a letter or a prescription sheet with all your medications. And in fact, I was just recently traveling to Italy, and when I went into my pharmacy to get some stuff, and I said, I'm traveling, she printed out a whole sheet for me, and then a smaller version as well to keep in my wallet. So all my medications were on there with full names and dosages and all that. And carry on luggage, again, oh my gosh, you need like a whole suitcase to go on with you. You need to have your meter, your test strips, all your diabetes medications, especially your insulin, the fast-acting glucose with you all the time, and having your glucagon with you, especially for super long flights. The one thing that always gets forgotten about glucagon is having someone who knows how to use it. It does you no good if no one knows how to use it or knows that it's on you. Make sure you have ID, and again, making sure you have ample food. Okay, and let's see. Scanners and x-rays, I like to bring that up because it's becoming something more and more as we see lots of devices at the airports. what can go through. So you've got all this carry-on stuff. My shout out to people who might be on insulin pumps and who may educate or know people on pumps. It's always important to have a backup pump with you when you travel, but it's important for you to put it on your waist and not let it go through that x-ray on the belt. You can walk through it with it, but you don't want it to go on the belt. And as well, you can walk through the scanner machine, but don't go into the body scanner where they have you put your arms up with your pump on or your CGM. You should remove it or ask for a pat down. So that's really important. Okay. Oh, and that would be the end.
Great. Thank you so much, Teri. You went through so much valuable information. So now it's time for questions. So if any of you have a question for Teri, please feel free to type it just in the Q&A box there, and we will definitely get to your questions. It's more of a comment from Christine. She says, my accountant didn't know if insulin really qualified. You must be your own advocate because no one else will. So Teri, that's something you really touched on, the importance of advocacy. Was there anything else you wanted to add on that note?
No, and that says it all. A lot of accountants don't know, and you need to go to actually Revenue Canada and read through the sheets yourself. And there's a lot of information also available. Again, I got a 2-pager about it, even on BC Children's website. They kind of give you information as to where to go. And finding those sheets really helps you as well to how to work through it all.
Okay, perfect. And Stephen is asking if a recording of this session will be made available, and I can answer that. Yes, Stephen, it should be available on the Canadian Diabetes website as long as there weren't any, technical issues. And Nancy is asking, Teri, if you could provide at some point a link for information on family caregiver AMT and children's fitness AMT. If maybe you could email the Diabetes Association that link and they can blast it out to everyone.
Sure, yeah, no, we can do that. I mean, most of it's all about, where I found it was, it's that darn Revenue Canada stuff. You have to go through and find it, but we can definitely find it.
Okay, perfect. And Gwen is asking, can you please go over again the requirements for the T2201 and what helps to fill up that 14 hours?
Oh, absolutely. So the activities that count are monitoring your blood glucose levels, preparing and administrating the insulin, calibrating necessary equipment, so whether that's meters or pumps, CGMs, and maintaining a logbook of BG levels. And again, things that do not count are counting carbs, exercising, recovering from hypo or hyperglycemia, and meal preparation is something else they put on there as well. Okay, perfect. And I just have a comment again, not a question, from Serge, and he says, the CBA will be launching its updated guidelines for kids in school with diabetes next Wednesday, September 3rd. So I just wanted to make everyone aware of that. Thanks so much, Serge, for mentioning that. Hopefully kids will be in school on September 3rd, but we're not really too sure at this point. Iris says, how would you bring your employer on board with your requirements for breaks even when others aren't entitled to them? Like, how do you do it in a diplomatic way? Yeah, that's a hard question. I mean, I think that it's so individual for each employer. And to some degree, I think that it goes back to what are the guidelines on required breaks. And I think that what's happening is people are not even getting, people without diabetes aren't getting their required breaks as well. So looking at how we could engage advocacy in that, and I'm not sure who you would start with, but certainly if there was, a union involved in any of those cases, you'd be able to get that advocate. But starting to ask the question is the first place to start.
And you touched on this a little bit in your presentation, but do you think it's really important to let your employer know that you have diabetes? Or is it personal for everyone? I mean, it's a personal thing, right? So not everyone's comfortable, but do you think it is important to alert your boss?
I mean, I think, again, it comes down to personal circumstances. You know, I've had patients who say there's absolutely no way that they're going to do it because they've heard somebody else disclose something medically and seen what has occurred. So they've made that choice, but they are proactive on safety, but maybe they've told somebody that they work with. Because, again, I think it's really important that they know that somebody knows how to treat hypoglycemia if necessary, because we know that that can be taken as different ways where people have been reprimanded because they were being aggressive or reactive when really they were just having a low blood sugar. So, again, making sure somebody knows that you have diabetes.
Okay. And a question here from Christine. I'm not sure if you'll be able to answer this, Teri, but she says, what is the CDA doing to get the new child guidelines into each and every school? My son's school has 4 kids with type 1 right now. How do we educate them on this major change?
Yeah, I mean, I'm kind of curious, and I think that's why I wanted to bring it up on this conversation with the fact that it has just occurred in BC, and now it's time to say, I mean, it's always about making that precedent and banding together, and I would say it was definitely about the parents that made the difference in making this happen and banding together. So I think that needs to have that ripple effect. Some of the provinces do have things in place, but not as extensive as what we're going to have.
Okay. So it doesn't have to be in every school right now, and it certainly won't be at this point?
No.
Okay.
Only in BC at this point.
Okay. Another question from Gwen. When you apply for a job, do you have to say that you have diabetes? I know you said that you don't need to tell if already in a job, but what if you're just applying?
Yeah, you don't have to disclose it. It's completely, medical information is completely confidential. It's your own choice as whether to not to disclose.
Okay. Perfect. So that's it for questions for right now. Maybe I'll just put the call out. If anyone has a lingering question, there's no such thing as a stupid question. Don't be nervous. You just have to type it in. Teri, I will ask you, I know you just gave a 45-minute presentation, but if there was 1 or 2 takeaways, what would they be for the participants tonight from you?
I think it goes right back to the beginning about it's really about being your own best advocate. I laugh, even as a healthcare provider, I can't tell you the circumstances I've put myself in not being allowed and saying things for me, for taking care of me. And so you need to take care of you, but also engage those close to you and around you. And you know, as an example, I was having surgery one time, and the doctor said, "Oh, I see that you have an insulin pump. Where's it implanted?" And I thought, you know what, I don't think I want you doing my surgery and being my anesthetist. And I was afraid to say anything. And I asked about all the right questions about what they were providing, and I knew that it was dangerous for me. And so I went back out to another nurse there, and she said, you don't have to accept that. If you're that scared, you need to speak up, and you need to get another anesthetist. And, you know, I thought, oh my gosh, I could have left here and accepted that. And this woman was a great advocate for me. So you never know, you know, having these people around you. I'm done.
Okay, perfect. Well, I think that wraps up all of our questions. Oh, we have one more from Krista. Did you wear your insulin pump during surgery?
Yes, I did. I had a few procedures, and I was adamant about wearing my insulin pump because I'm very insulin sensitive. But I did have to find another doctor because my doctor didn't have privileges at the hospital I was having surgery, so I found another physician to write a note saying that they were not to remove my insulin pump unless there was an emergency that had to be dealt with. So I've worn it numerous times very effectively.
Okay. And a question from Roxanne here. Are you aware of any type 1 chat groups? sometimes it's nice to vent out with type 1s or ask for advice. And Roxanne is located in White Rock, BC.
Let me look at some that I do know that there's a few around from some of my patients that do use them, and I can email that in to you as well.
Okay, and we've also had a couple people asking if they could get a copy of your slides, just because there's been a lot of valuable links and information on there. Would it be possible for you also to email that to the Diabetes Association?
Oh, for sure. Yeah.
Okay, just so that people can, I just think some of the links would be helpful for people to be able to maybe follow up on. Yeah. And Christine says, some hospitals have varying pump protocols. You must find out what the hospital pump protocols are and advocate for yourself. Often they do not alter the pump. So again, more of a not a question, but just a comment from Christine there.
It's absolutely important to do that, and even some of the major hospitals are resistant. So you really have to push. And I was even able to negotiate having somebody come into PAR and take care of my blood sugars and manage my pump. So it's about advocating and proving that it's worth it for them too, because boy, oh boy, did they start to love pumps.
Okay. Christine says she works for a diabetes company in Thunder Bay, and her son is also type 1. So that's why she's so knowledgeable and why she's had so many great questions. So if anyone would like the slides, you can email infobc@diabetes.ca, and they'll do their best to get those to you, just because there was so much valuable information on them. And and Stephen says to try alt.support.diabetes for a support group. So if people want to check that out. But then he adds, listen to your doctor and not people on the internet, which is great advice, obviously, to listen to your doctor over chat groups. But sometimes, as Roxanne said, it is nice to vent and meet other people with diabetes as well. So Teri, I'd like to thank you so much for joining us tonight, and your presentation was interesting and informative. And of course, thanks for everyone who attended the webinar tonight. And we'd like to remind everyone that you'll be sent an evaluation survey tomorrow, and we do encourage you to complete it. It should only take you a couple minutes, and it does provide valuable input for the Canadian Diabetes Association. And I've been plugging this every time, but if you haven't checked out My Diabetes Charter, please do so. You can check it out at mydiabetiescharter.ca. The development and delivery of impactful programs such as our new Canadian Diabetes webinar series is made possible through the generous support of our donors. If you enjoyed this webinar and would like to make a donation, please visit our website at diabetes.ca or call 1-800-BANTING. Thank you for your support, and thank you everyone for participating in tonight's webinar. Take care, and thanks so much for your time, Teri.
Thanks a lot.
Okay, have a good night.
Thank you. Bye-bye.
Bye.